Great, well, we will get cracking. So good evening, everybody. Welcome to, I don't know what number, 5K Your Way Facebook Live. We started these in lockdown. We've continued them when lockdown left, and I think they're now a permanent fixture. So this evening, we are delighted to welcome back Rebecca Robinson, who was with us on our first 5K Your Way Facebook Live back in March. So lots of you will know Rebecca. She's one of our Sheffield ambassadors. She's a sports and exercise medicine consultant with a special interest in exercise oncology. I really don't think there are many doctors out there who know more about exercising during and after cancer than Rebecca. So Rebecca, thank you very much for joining us once again. And we're also super excited to have Melanie Thomas, or Mel Thomas, who is the National Clinical Lead and Director for the Lymphoedema Service in Wales. Mel's a physiotherapist by background. We've had loads of questions about lymphoedema, and we're so grateful, Mel, for you giving up an evening to join us today. So thank you very much.
Thank you, Mel, and Rebecca.
And obviously, everybody knows me. I'm Lucy Gossage and Gemma and Hillier-Moses, 5K co-founders. So tonight is going to be a little bit of a Q&A. We've had you guys sending in some questions. What do you want to know about exercising cancer? And given we've got Mel with us, we thought we would kick off by talking a little bit about lymphoedema. So Mel, can you tell us what is lymphoedema?
Okay, so you'll have to excuse the Welsh accent. I will try and go a bit slower because us Welsh tend to talk very fast. So lymphoedema, it's a chronic condition, and that's one of the scary things. So people say, oh my gosh, lymphoedema, I don't want to get that, I'll never get rid of it. But you must remember, lymphoedema comes in all shapes and sizes. So lots of people will just have a mild swelling and it can be managed. So lymphoedema is a chronic edema. It is swelling, and that's one of the main symptoms. Pain is another symptom. Lots of professionals say, oh, you can't get pain with lymphoedema. Well, let me tell you, yes, you can. We're doing a lot of work at the moment with PROMs, so patient-reported outcome measures, and pain is the #1 thing that all our lymphedema patients are saying. So lymphedema, chronic swelling, it occurs because it's two different reasons. It's a primary, and that means you're born with primary lymphedema because you haven't got enough lymph nodes, or the genetics with the lymphatic system isn't quite right. And then secondary is because something else has caused the lymphedema, and that's where cancer patients come in. That's where you get lymphedema. So it could be because of the cancer itself. It could be because you've had surgery that's taken away some of those lymph nodes, or it could be radiotherapy, because obviously radiotherapy can affect the lymph nodes, can make them quite sluggish. Lymphedema affects the young and the old. It is far more common in the elderly, and that's because our veins, who work very closely with the lymphatic system, once they slow down, then that can cause some problems with the lymphatics. So people always say, what is this lymphatic system? Well, think of the lymphatic system as your recycling system. So it's a system that works all the way around the body. It is similar to the vascular system, and yet it decides what's good, what's bad. So a bit like our recycling, where we put, you know, the tins in the green bags, or your plastics in the pink. That's what the lymphatic system does. It ends up in lymph nodes, and we've got lymph nodes in our neck. We've got them in our underneath our armpits, in our elbow, in our groin, knees. But we've got two big central ones, sort of in the chest area, and that's where it siphons into, and eventually goes into the kidneys, and the lymph wheeze out, so to speak. So that is lymphedema. Now, lots of people think, okay, so I've had breast cancer, am I going to get lymphedema? Well, to be honest, it depends on, there's risk factors. If you have all your lymph nodes taken out, then your risk is higher. But overall, with sentinel lymph node biopsy, where they're only taking some, the risk on average is about 1 in 5. If you're looking at prostate cancers, the number is quite unknown, but we estimate it's around 10% of people. And again, it's more if you've had inguinal surgery. So those groins in your lymph nodes, if they're affected, that's why the risk is higher. But, you know, it can affect people with gynecological cancers. So your vulva, what other ones I'm trying to think, your melanomas, your skin cancers, your head and necks. So it can affect any part of the body. But the good thing about it is there's 4 different things that you can do. Skincare, moving your body any which way you can.
We like that one.
We like that one. Yeah, we love that one. Any which way you can. Compression garments, and then there's massage. Those are your 4 types of things, 4 cornerstones of care that can help you. So how's that? That's lymphedema in a nutshell for you.
That's the best
amazing.
explanation that I've heard. I think all medical students should be given a similar explanation. I guess the only thing I would add is that cancer is often spread via the lymphatic system, which is why lymph glands are taken out for quite a lot of people with cancer. Lymph glands would be part of their surgery. So we know what lymphedema is now. We know a little bit about why you might get it. Something that people often ask is can I exercise with it? So we've got a question from Little Lenses on Instagram. I think this is a really good question to just delve into a little bit. So the advice around lifting any kind of weight or doing weight-bearing exercise after lymph node removal, and I think they've had breast cancer, is really confusing and contradictory. Yes, it's fine and even beneficial versus no, it's don't do it. It would be lovely to know if I can do a burpee or a push-up. Any kind of advice really gratefully received.
Okay, so this again, it's historic issues. So if we're going back to like the 1970s, 1980s, lots of good meaning professionals got together and they came up with what they thought was common sense information that they should give to the general population. And exercise was one of them. So it used to say, don't do any repetitive activities, don't do any extreme sports, don't do any extreme lifting. And then when people used to say, well, how much am I allowed to lift? They would say, about 2 kilograms. And then you think, well, 2 kilograms, I'm only allowed to lift 2 kilograms. Oh, no, you can lift 3 if you want. Oh, or maybe you should lift 4. Well, I can tell you now, after spending 6 years of my life doing a PhD, there is no evidence to tell you that you cannot lift, that you cannot exercise. The evidence actually suggests that you are less likely to develop lymphedema if you actually move your body and you exercise. And when I say exercise, that's resistance exercise, aerobic, anaerobic exercise. So definitely, they're all myths. And we have to change that ruling so you can exercise. But what I would say to you is, if you've never run a marathon, you're not going to start running the marathon the next day. You need to start slow. So if you're talking about lifting weights, then start, if you've never lifted anything before, start with 2 kilograms. You do repetitions of about 10. The next day, you increase your repetitions. You may go to 15, you may go to 20. The next day, you might think, I've got no problems at all. I might start going to 3 kilograms. Now, the advice I would give to somebody in their 80s would be very different if I was giving advice to somebody in their 20s or 30s who, normally rock climb. They normally go to the gym 5 times a week. And I think that's the big issue that we've got at the moment with the NHS. We give this, everybody is given the same information, but everybody is different. So for that particular person, I would say definitely, if you've always done burpees, you do your burpees. But just be aware, you're not going to start off and do 100. You're going to start off and do 10, see how you feel and work your way up. So it is common sense, but lots of people, when they're told you can't do it, that's not right. Yes, you can do it.
So that is the most helpful bit of information that I've heard about lymphedema ever, I think. So just following on from that, Becky Lineker has said, it would be great to learn more about aftercare following surgery. As mentioned above, it's a very contradictory subject. So from what you've said, it sounds as though as long as you build up gradually, then exercising after surgery is not only it's not just something you should avoid, but it's something you should actively do because it might help and reduce the risk of getting it. Is that fair?
That is correct. So the evidence that's out there, and there's lots of randomized controlled trials, there's been literature reviews, systematic reviews, and what it says is exercise does not increase your risk of developing lymphedema. It also says that if you have lymphedema, it won't actually exacerbate it. So it won't make it worse. What the evidence is lacking is if exercise will actually improve lymphedema if you've got it. However, there are a lot more trials which are happening, and I can tell you from a clinical perspective, I still see patients, you know, on a regular basis. Those patients who exercise, who move their bodies, they will get a reduction in the swelling. They will feel better. Their muscles will feel stronger. So their whole ethos will be better. And that's why we all need to move. I think the problem we've got now, you know, for the majority of people, years ago, they were told, rest your arm if you've had breast cancer, you know, nurse it, don't do anything, or don't do stretches, don't lift, don't empty the kettle, don't empty saucepans. That's rubbish. We've got to move. And we've really got to use our joints, because if we don't use them, they will feel worse. And you're right, it will increase the risk of you developing lymphedema if you lead a sedentary lifestyle.
So I was just going to jump in there, actually. Yeah, that's brilliant, Mel. And I was just going to jump in around, and Rebecca, you might know more about this as well, but the American College of Sport and Exercise Medicine do have some good resources around lymphedema if people want to find out more in terms of some more specifics to them as well. So some resources that you could access. And I know we as Cancer Rehab instructors look at those resources, and Sarah Russell, who was on one of our question and answers recently, refers to that in her book as well. So if people want to look more into their specific circumstance, those resources can be really useful as well.
Yeah, and I think the other thing to mention, if we're talking about breast cancer, often people will have extreme tightness in their armpits, in their axillas, and that will actually restrict a lot of movement. And again, it's because they're not stretching properly. They can't feel underneath their arm, especially if they've had radiotherapy because of the sensitivity issues. But they need to get their hands in and massage underneath. The more hands-on that you can actually touch your skin, feel the actual area, that's the best thing. Because, you know, again, I meet lots of patients who are afraid to touch their scars. They're afraid to touch underneath their arm because they can't feel it. They don't want to touch it. And then I say, okay, when you go in the shower, get a shower puff, get a flannel, you know, really rub it and massage it. And those patients straight away, they get more sense as to what is normal for them. So definitely hands-on, massage, moving the scars, exercise, it's got to be the way forward, and stretching.
And we're going to link to these. You and your team have made some really helpful videos about lymphedema. So all parts of the body, exercises that you can do, how you can massage. So we'll share links to those on our show notes. Mike Willer's got a question about compression socks. So last year I had surgery for a melanoma on my right calf. All good now, but I had complications relating to the removal of the lymph nodes in the groin. I had quite a lot of swelling in my lower leg, and even now my ankle area gets puffy. Do you recommend compression socks for running?
100%. I recommend compression socks for everybody. I personally wear below-knee compression socks. If I'm out walking the dog, they're on. Day to day, especially now where we're all sitting, you know, I feel sometimes I'm going to end up like a chair. So I've always got my compression on, and I would definitely recommend it. You know, lots of healthcare professionals, when we see them, we always say, get some compression on. So for him, there are running socks available, which are compression. I've got a pair myself, and they do help. And when you think about a lot of sports stars now, our rugby team, but don't look at their, you know, they've lost their last 2 games, but they actually wear compression post-game. And there is a lot of mileage that we should be looking at the benefits of compression. So 100% he needs some garments. However, what I would say to him is if he's got swelling, he needs to be referred to the local lymphedema service. If they can't find a local lymphedema service, they need to contact BLS, which is the British Lymphology Society, or LSN, which is the Lymphedema Support Network. Both you can find, you know, on the internet, but there are local services, and, you know, they can help you.
We'll put links to those as well. And just one final question from me. What about having needles in your arm if you've got lymphedema, for example, you know, or blood tests and things?
Okay, so this is a real controversial. It is, when I did my doctorate, this was one of the main points. Everybody had lots of angst and anxiety about it. The evidence around needles and injections and blood pressure came really from the 1950s. Now, surgery today is extremely different to what it was in the 1950s when it was radical. So the evidence out there is actually very limited. But what I would say to people is, if you've had a sentinel lymph node biopsy, you've only had a couple of lymph nodes removed from your arm, then I would say you need to live your life as normal. And that means, yes, you can have blood pressure, yes, you can have injections, flu jabs, anything that you need. If you've had an axillary lymph node clearance, so that means they've taken all the lymph nodes away, then I would say, if you can, use the other side. However, life and death situations, out of the park, they can use whichever arms they want, because then your lymphedema specialist will sort it out. But lots of people get hung up about this blood pressure and injections, and there's no evidence for them. And yet they forget the exercise bit, which there's lots of evidence for. I must also say as well about body mass and BMI. Those people who have got a BMI over 25, over 30, their risk of lymphedema is much, much more. And again, that's why exercise is so important, that we can actually try to lose or maintain a bit of weight. And again, for some of my patients, I may not say that you need to lose weight, you just need to stay the same weight. Once you can master staying the same weight, then we look about trying to lose weight. But yeah, there's lots of problems over blood pressure and injections, but there's no evidence for them. But as I said, sentinel lymph node biopsy, have it, do not worry about it. They shouldn't even be told that it's a risk. Those who've got an axillary lymph node clearance, as well as if their BMI is over 30, I would say if you can, use the other side, but do not worry about it. It's not the main thing.
What helpful advice. I mean, I don't know about you, but there have been a lot of myths debunked there, Mel. So thank you very much.
That's absolutely incredible. And I was just about to say, because I know Lucy's hosting, but we've got some comments saying, great advice, Mel. And I think we could do a workshop in itself on this topic and having you present it. I could listen for hours. Yeah, it's really, really great.
Yeah, I'm more than happy to come back. I can talk to you. There are so many myths. You know, when I started this journey, there was people saying, oh, do not wash your hands in hot water. Do not clap your hands together in the theatre because that will cause lymphedema. And these are dreadful things. There's no evidence for them at all. There's three things which there is evidence for. The first one is get your weight. Get your weight to a BMI 25 if you can. But that's the first one. The second one is about exercise. Move your body each way you can, any way you can do it. And that may well be for some of my patients, you know, who are morbidly obese, even just standing up, standing on the spot, you know, starting off, just do 10 steps while the kettle's boiling. When the phone rings, stand up, do a few steps. That's the things we say. So move your body, weight. The third one is skincare. And that, again, use any creams that you like, but moisturize your body, moisturize your arm. Us ladies, we always moisturize our face, but we forget about the rest of our body, and men are hopeless. So really, just get some cream, moisturize your arms if it's breast cancer, if it's legs, you know, with prostate, if it's gynae, melanomas, moisturize with anything that you want to use, apart from aqueous cream, because aqueous cream is just a washing agent. So it just needs to be, you know, your Vaseline Intensive Cares, your Doves, anything that you like, really. So those three things.
Amazing. Well, we would love to get you back and do a more detailed workshop at some point now. That is brilliant advice. I've learned loads, and yeah, it's definitely debunked a lot of myths. So let's move on, because we do have a few questions, a few more topics we want to talk about. So we'll talk a little bit about aches and pains in the joints, so arthritis kind of symptoms, or arthritic kind of symptoms. So Nikki Day, just to lead the topic, has sent in a question saying, osteoarthritis from non-Hodgkin's lymphoma is starting to rear its head everywhere. What exercise and nutrition advice do you all have? I ride about 100 to 150k a week on Zwift and try to lift compound weekly. So we're not going to go into specifics, but Rebecca, perhaps you could talk a little bit about arthritic symptoms. It's something that we see commonly in people, particularly on hormone treatment, but there are lots of different causes, and whether there's anything that people can do to improve those and minimise them.
Thanks, Lucy. Again, as you said, it's a tricky area to be really specific, but we do see this a lot in people after treatment, such as Nikki's case, but also on different hormone treatments. Arthritis in itself, without cancer, can be osteoarthritis, which is a bony wear and tear, or inflammatory arthritis. And actually, after cancer, it's quite common to have a kind of, even if it is a bony wear and tear arthritis, it can be quite like the inflammatory type. So it can be that it flares sort of unexpectedly, obviously causes a lot of pain in the joints. And for some people, slightly separately, but on hormonal treatments, those pains can be more in the tendon. So where the tendon, kind of, even if it is a bony wear and tear arthritis, it can be quite... Just waiting for, there's a bit of feedback on there. Not sure.
I think we were hearing ourselves again, or Rebecca again. That's fine.
Not sure how, but I don't know, repeating myself already. But basically, for some people it can be in the joint itself, some people it can be in the tendon right where they insert in the joint, but basically it can cause a lot of symptoms, a lot of pain. It can be worth if you are experiencing that after a specific treatment, or you're experiencing it on a hormone treatment. If it's really becoming something that impacts you day to day or impacts sleep or activity, checking in with your consultant just to find out, is it related or is there anything else that could be causing your pain? So, but that aside, it's important still to be able to move, and actually movement can help. So if you can maintain the strength in the muscles, then that's going to really, really protect the joints. Sometimes if you've lost strength through cancer, and things like we mentioned before, very useful, I think, Mel, like on body comp, things have changed. Sometimes people will have lost not necessarily weight, but they will have lost muscle mass. So actually, sometimes getting that back after treatment can be a little bit slow. And if you know things like hormone have shifted because you're on a treatment, or because the treatment has affected them, that too can make it slower. But I think it's not being discouraged. Just like start doing a little bit of movement. Sometimes, you know, seeing if your joints are really sore in the morning, you might do good just to stretch out a little bit, do something like a little bit of Pilates-based, yoga-based, simple stretching. I know you've done a few really good ones of those on here, I think, too. But just trying to do things to get that gentle movement and then building up slowly. And then if you've already got or been used to, I think, such as the Nikki who's content is, if you're used to lifting, maybe not setting those big goals at first, but just kind of like breaking down what you normally do. If you're normally in the gym, obviously we have to all gym at home at the moment, but just putting back in body weight, getting some more weights, building up to things slowly. And the same in terms of cycling, it might feel frustrating that you've got to go back a little bit if you've got those symptoms, but just building up a rate that's good for you. But I think it is important to know that yes, exercise can definitely improve these symptoms. Exercise has got a big anti-inflammatory impact. We know that in osteo, we know that in rheumatoid, we know that in all sorts. We probably haven't got the evidence base as strong as we want it in exercise and cancer, but we do know it helps. We think it may also help with cancer too, it's a whole different topic. But if you're getting to a point where actually it's really stopping you from being you or doing your exercise, then maybe just checking in on what's driving that too is helpful. And the other thing I didn't answer is good stuff around nutrition, anti-inflammatory foods. There's lots around things, and you don't have to spend loads of money on it, but all the good sort of, if you can eat them, cruciferous vegetables, your kind of broccolis and that, and your onions, and anti-inflammatory, antioxidant type things, red berries. Vitamin D is underrated for sunshine vitamin. We don't get enough of that. So just the kind of basic good health things. But for some people, things like omega oils, things like a bit of collagen. I mean, there's a lot of that in jelly, so you don't need to buy expensive supplements. But just kind of looking around those good things to support your nutrition can help the joints too.
And just as you know, we keep coming back to this in these Q&As. If you have something that's affecting your quality of life, don't be scared to talk to your consultant about it, because they might be able to change your medications. If you're on hormone treatment for breast cancer, it may be that a slightly different version of the same medication can make things way more manageable. So don't ever be scared to bring things like that up at your consultation. Mel, Gemma, have you got anything you'd like to add?
I think, Rebecca covered really, very comprehensive covering of that topic. So no, I think I'm fine with that one.
Yep, same.
Okay, well, moving on. So again, it's a very broad topic. We can't get too specific. But Victoria McCarthy, I think this is a really interesting thing to discuss, actually. And there are a lot of myths and differing opinions about this. So Victoria McCarthy has said, I read there's an increase in the risk of bone fractures during exercise if you have secondary breast cancer in bones. Is this correct? And if so, is it just affected area? So this is a big topic. Who would like to dive in first?
If I do, it's going to have to be with some help.
I'll chip in as well.
Good, thank you. It's a great area to talk about. There's lots. We could probably have a whole talk on this too. BOMETs, like, I think that's where, like, for me, so my job is in sports exercise medicine, emphasis on the exercise really, because like we have brilliant people like physiotherapists, physiologists, even strength conditioning, who can work, and even in the NHS we definitely get physios, can work with people with cancer and help and support. But sometimes, like, medically it's kind of good to have a chat and know, and oncologists can do this as well, for sure. Sometimes we hopefully can help them out with a bit of time, but to know, like, where is the bone issue, where is the metastasis at, because that might mean that actually you do have to be a little bit more careful around loading that area. Such as someone's got a metastasis in their spine, we might be able to still work out a really good loading program, but we might not want to go straight in there with high intensity repetitive loading. There's lots of aspects to this, and I probably won't be able to cover them all, but we can just go briefly. Is things like actually around treatment. If someone's having radiotherapy, sometimes we see people have some more fractures immediately after their treatment, or possibly even during. Some people might be there for a somewhat higher risk for an amount of time afterwards. Sometimes that will sort of also settle, but we have to be careful around some of those loading, weight-bearing joints. And I think for some people that have metastases in more than one area, again, useful to know about where they are and what to avoid. A big way to overcome some of those things is to maybe focus straight on looking at the core stability, looking at loading, and that kind of means strengthening all the muscles that support the skeleton, but also supports the other muscles. So if you've got a big muscle like your quadriceps in your thigh, in front of the thigh, they are strong muscles, but they're also attached to bones at the top and bottom. So we don't want to stress them all of the time because they'll be pulling on the bones too. But we probably want to make sure that all those lower tummy muscles, the muscles at the back of the legs and the lower legs are all getting stronger too. So it might be that somebody takes a little time off if they were, say, running, that like they took a little bit more time off that running in one direction. Don't have to stop it, but you do a little bit of work all around the multi-directional loading. Maybe we need to think too about someone's bone density overall. We can assess their individual risk, and we probably want to say that, like, if someone's doing really high, like hyperextending their cells or really going to an extreme range of movement, are we really sure that we think that this bone can tolerate this right now? But we do know, we've got some really good studies in different areas in cancer, especially in prostate cancer, that getting stronger can actually protect the bones, but might also, excitingly, we haven't got all the strength and depth of evidence yet, but might actually reduce the risk of cancer coming back. So that's exciting.
Yeah, and I think just to highlight what Rebecca said, I think it has to be kind of that multidisciplinary approach with your team. And I know it, you know, some people will sit there, listen to it, say it's frustrating because they can't get the right team in place depending on who your consultant is, who you're working with and where you are, and that is frustrating. But if you can get that team in place to help guide you, that can be really important, especially with that increased risk of fracture. But like Rebecca said, there is no reason why you have to avoid exercise or physical activity, but what we have to do is kind of adjust your goals and your milestones for that. And that might be, you know, that, like Rebecca said, it's low impact exercise and activity, and there's still a lot that you can potentially do in terms of mixing your aerobic training and your resistance training to get the exercise you need. And I think there's something to say as well, it's not, we look a lot about exercise as a physical capacity, but also it's so important for our mental health, even with the side effects of treatment, to actually think about what it does to just move and actually help your mental health and how that affects you. So it is important to look at alternative things, and you don't just have to do nothing because you have some of these side effects of treatment. And I think what I've got a resource actually. So the Macmillan Cancer Care published a leaflet in 2018, so actually quite recently, on physical activity for people with metastatic bone disease. So that might be a good one. I mean, Georgie and we'll post it, but that would be a good one for people to look at if they want even more information as well. And I think it's available on the Macmillan website as well.
And I think from my point of view, it's knowing where those mets are, which part of the body, And remembering, if it's only in one side of your hip, say it's in the right hip, well, then you can certainly do a lot more with your left leg. You can do a lot with your upper limbs. You know, if you've always ran and it is in your hip bones, because it tends to be your hip bones and your humerus bone, that those are the common sites, then I would say, do you know what? It's the weight that's causing the issue. Go in the water, do some swimming. If you can do, you know, walking and running in the water, that's 70% of your body weight that's taken away. The other important point is to actually just remember the red flags. So if you have got bony mets, then things like pain, numbness, pins and needles in your feet, if you start tripping over things, if your foot starts dropping, if you've got any bladder or bowel problems, those are the type of things which are red flags, and you would go straight back to your healthcare professional to mention to them. But definitely, even with mets, you need to move as much as you can. And, you know, as Gemma said, it is important for your mental health. If this is something you've always done, then I would still recommend walking, you know, going out for a walk and within your limits.
And I think just to finish this point around that, I've had this experience as well of not being able to do what you used to do or what you think you should do. And I think one of the most important things is to remember is to try and focus on what you can do. Whereas I think from a mindset point of view, we often focus a lot on what we can't actually do. And then that takes away the headspace in terms of actually thinking, what can I do? You know, I might not be able to do what I used to do, and it can take some time to adjust to that. But actually, if you talk to your team and you know, get that advice and the guidance, there may be a lot of stuff that you actually can do. And it is about focusing on those things and not just the things that you're unable to do, which will help you feel a lot better mentally as well.
And I think just one other thing to say is doctors and nurses often don't know the answers, and when they don't know the answers, sometimes there's a tendency to just be very conservative and to say what they think is safest. So I would encourage you, you know, we are experts in treating cancer. We don't all know the evidence about exercising. A lot of us don't exercise ourselves. So if you feel that whoever's treating you doesn't know enough about exercise to give you a proper answer, then it is worth seeking out someone who's passionate about it, because the NHS standard answer may well just be don't do anything, whereas we're showing you, I hope, that if you want to, there is always a way, even if it's going to be very, very adapted and modified and different. But if you want to do something, there is always a way to do it. And as Mel has said, moving is good. So following on from this a little bit, we're kind of all joints and bones and nerves. So peripheral neuropathy. So this can be very disabling. So peripheral neuropathy is damage to the nerves that supply particularly your hands and feet. It's something we see quite often after lots of different kinds of chemotherapy. So Sam Katz has said, I've got peripheral neuropathy in my feet from chemotherapy and painful joints due to taking Tamoxifen. So this is just a kind of broad question to lead us onto it. So she's asking, or he, I don't actually know whether it's a he or she, but can you suggest any suitable exercises, please? So just talk a little bit, if that's okay, about peripheral neuropathy and whether exercise can be helpful and how you might modify exercise if you do have peripheral neuropathy. Mel, do you want to start with this?
Oh gosh, do I have to? It is a difficult one. The patients that I tend to see with peripheral neuropathies, you know, are more in their hands because of chemotherapy. We often provide compression gloves for those patients, and it's that static pressure that actually improves the nerves. Now, we're not talking high classage, you know, they're just low class gloves. That has actually helped. But again, you know, skincare, massaging, you know, massaging your hands together with different oils and creams. It's just that the nerves are desensitized. You just need to try and stimulate what you can. So even any form of exercise, again, is important, but it's to your limits and what you're used to doing.
Yeah, and I think just to add to that, I've worked with quite a few young people who've had peripheral neuropathy, and I think, like we were saying, the grip, exercises can be really important. So even like the stress balls or the hand, you can get some hand grip exercises. And I think, you know, obviously every case is different, but working on balance to everybody can start with just a little bit on one leg, holding onto the side, and progressing that to be on bozo balls and all sorts of things to progress that to really help with it. But if you are really struggling with your, you know, that balance and that, the loss of balance and grip issues, there are the static machines that you can use as for a general exercise. So like being on the bike or seated calf raises and that sort of things, and then get your strength and your fitness there, then progress as your confidence progresses to those balance and grip exercises as you go along a program. So I think, yeah, from that point, there is plenty that you can do to help it, as well as keep fit and healthy alongside of that as well.
Rebecca.
Yeah, I think all those are brilliant points, and we learn a lot like from treating each individual. I think really good points, Mel, about having that strength, the static strength that can improve. But I think as well, there is a little bit of evidence, I'll say this little bit, in almost everywhere, probably lymphedema the least, because there's some brilliant work, but we've still got an awful lot to learn. So there is a little bit of evidence around even peripheral neuropathy that actually exercise can really help. So it can help you can get the strength back, but it might hopefully for some people improve their symptoms. So I think, you know, for Sam's question, getting a static bike or row machine can be really good. But like Gem says, even if you started doing some seated exercise and working on balance tentatively there when you're safe, and then progressing it to kind of looking at single leg, looking at kind of having something like a wobble board, that can all help. And definitely things like yoga, Pilates around that, just to keep things moving, keep everything strong, of course. And again, sometimes it does mean being a little bit more careful when it's really cold outside. You want to just be a bit preemptive with things like gloves now that we're in, well, it's in a funny warm spell, but in the middle of November right now, you know, you might want to just make sure you're warmer so that that doesn't become something that's unusually painful or just puts you off when you go out too.
And anecdotally, and I don't know the evidence, but lots of people seem to say that acupuncture can be quite helpful for peripheral neuropathy. So it can damage the nerve fibers. So peripheral neuropathy can either be painful, or it can mean that you can't feel things, or you've just got numbness. And it can be, I know it can be very challenging to deal with. We don't have answers to everything, do we? But at least we can signpost a little bit.
And can I just also say, I think what's really powerful, and we always say this, is people's stories and experiences. And I know sometimes like every individual is really different, but you can get some inspiration, and also who people have potentially worked from or got their advice from. And we've started to pull together a lot of blogs from our community of people writing their stories or sharing their experiences and dealing with certain side effects. So if there is anybody listening who would like to share or would like to see more of those blogs so that they can learn from them, they are on our website. Because I think stories, you know, the evidence is amazing, but like we learn when we've worked with people and realize everybody's different and everybody has their own way of doing things and learning. So I think it's such a powerful tool as well.
Absolutely agree. So moving on, and this started with a question from Claire Wookie, who said, I'm currently having treatment for breast cancer, and normally I'm a big swimmer, both indoors and predominantly outdoors, right through the year where possible. I'm starting dose-dense chemotherapy on the 22nd and have been advised not to swim. What are your thoughts? I'm having a port fitted, so I believe I can swim with a port, ? So we're not going to have an answer to this, but we can discuss the pros and cons of swimming, perhaps have a little bit of a conversation about why people might be concerned about you going swimming, and what other things you might want to think about, and kind of alongside that, perhaps talk a little bit about exercising with lines. Rebecca, do you want to go first with this? I know it's a
yeah, for sure. I'm going to get the oncologist to talk people through all the different kinds of lines just to make it more simple than I'll do. But I think, you know, and again, we've got like a good half hour in and we haven't mentioned the word COVID, which is quite good. But like, I guess in different ways, that for me means, you know, if people are thinking of indoor swimming, which I think most people will be right now, but again, lots of people do enjoy outdoor swimming still. That's not on the cards for a lot of people, but that's temporary. We hope that is really temporary. In general, it would be better if swimming is your activity and you're careful around keeping a port clean. You can like be careful on the area, especially you can swim with a line. Yeah. So we can go into the specifics in a bit, but it is possible, and it's sometimes that we just say no, as Lucy said, when we don't know. I'm hoping that the sports side of my job is working with athletes, and we work with para athletes with all different disciplines, and actually we always try to find a way. So if someone can't do it one way, they can do it another. So it's all about the individual right there. So it's going to be about what your treatment is, how your line has been, what the exact specifics are around it. But in general, it's not a blanket no, Claire, for sure. I think at the moment, like if you can't get access to a pool, you might want to think about, if you're swimming outdoors, is that somewhere that's really clean? Can you keep warm? Is that, safe for you? But I think the other thing is that if you're not swimming at a time, or you've just had treatment and you want to be that bit more cautious, or at the moment, if you're in what was that vulnerable group, or your pool is when your pool is open, but also when your pool is closed, you might want to think about like increasing some light water like activities, like being on a line where you can pull with your arms and out of the water, like swim cords, that kind of thing, doing some out of water activities to keep you with that breathing rhythm. There's actually some things that you can do that are quite fun. Lucy will know more because she's a triathlete with swimming background. So there are things to think around it, but there's a lot you can do.
So I think something that so just different kinds of lines. So porta cats are very different. So porta cats are oh gosh, how am I going to describe this in simple terms? They are kind of buried under your chest wall, so it's a closed access, and healthcare professionals can put a needle in, so you get a little port where you can take blood and inject drugs into it. PICC lines are tunnel lines that go into your arm, and they have an open lumen. So I think there is a difference between what you can do with porta cats, which a lot of hospitals don't actually offer, and PICC lines and barred lines, which is another kind of line. One of the big concerns is around infections, and I don't know, Mel, what your thoughts are on infection risks and swimming, and how you might counsel someone who really wanted to go swimming who was on chemotherapy.
I think it always goes back as to what is really important to that patient. What is really important to you? What we do in Wales is very much value-based healthcare. So this particular person, swimming may be their lifeline. So they may go swimming every single day, and for us to suddenly say, no, you can't swim, that is like pulling the lifeline away. So I would work with that individual to try and decrease the risks as much as possible. And that may include things like Rebecca said about, yes, keeping warm when you come out of the water, but also, can you wash as soon as you come out of the water? The biggest risk factor is obviously that if you're having chemotherapy, your immune system is already lowered, and then suddenly we know there's lots of bugs in swimming pools, even though they're chlorinated and everything. We know there's lots of bugs even in outdoor swimming areas. So we need to suss out how clean this particular water is. Have you ever had any issues previously? We need to look at your cycle of chemotherapy. Is there more likely to be a less time when you're less at risk? Now that may be towards the end of the chemotherapy cycle before you have the next one, but we really need to work with those individuals. I've often put Tegaderm, which is like a plastic covering, to cover up the port. And I just say, okay, if this is so important to you, then I will work with you from it. But they need to know the signs and symptoms of an infection. If the neutrophils are increasing or whatever, we need to know what will happen if that does occur. But again, it's working with individuals. What is really important?
And I think, like Mel says, it's about looking at when in that cycle of chemotherapy, or when can you do something. There may be a period of 1 or 2 weeks when your neutrophils are really low, and actually that's not a good idea. But then actually coming out of your cycle or in between, you might be at a level where that's fine. So it's also making sure that communication with your healthcare professional is quite regular, so that you are able to then understand what your body's going through. So understanding when might be better to do something and when might not actually be too good to take that risk. But I really liked what Mel said about that patient valued healthcare in terms of looking and enabling somebody to do something. So coming to me with a solution, not a problem. It's kind of like, what solution can you give me and how can you help me, even if we have to adjust what I can do. I think that's so important.
I had a patient recently who's a horse rider, and she'd been told she's not allowed to go horse riding because the lymphedema is getting worse in her arm, but actually that's her life. So we said straight away, okay, this is what we're going to do. We're going to wear double layers while you go horse riding, and then as soon as you finished your horse riding, you just take the second layer off. But she'd seen, I don't know how many professionals who'd all told her, stop horse riding. And that isn't, you know, we know, yes, okay, it will probably be easier if you did, but that's not right for that individual.
That sounds like a bit like me when the consultant told me I couldn't run for a year post chemotherapy, and I just went and tried to find somebody who could give me the right answer that I wanted. So yeah.
And your experience is really fundamental, because we experience this in sport. Like most of the athletes that I work with, say in parasport, you know, if someone said, and I have had calls from GPs going, well, they shouldn't be lifting weights like that. And if you watch the Paralympics, you know that that's exactly what they should be doing. And of course, if like when we've got to adapt things around injury, I can't sit there seeing them as a doc saying, oh, well, you can't do that. We have to find a way, and we do, or they usually find a way and we support it. But I think that's where it's exciting. And I think important, we've got to get the evidence for things in exercise medicine. I think most of us on this panel and hopefully some people watching will be involved in like trying to get that evidence, which is crucial. And like Mel, you've already done, but then actually really it's got to be individualized medicine for what is right for that person. And that's the really fun part of my job anyway. So finding a way. Yeah.
And I think, again, it goes back to, you know, what's harm? Yes, okay, you know, this person swimming could cause harm, but actually her not swimming could cause significant harm. And then we've just got to weigh up what's the right thing to do.
We want to be enabling rather than disabling.
Yeah.
Just quickly, something that I've seen on Twitter, someone asked me recently, and I didn't actually know how to answer it. Over the head exercises, if you do have a line, do any of you have any advice or guidance about whether you can do over the head exercises with a line?
I think again, it's like I haven't had any hard and fast. You absolutely cannot, but it would be good to know the specifics for that person, exactly what they're, you know, they're going to do some body weight exercises. Are they really trying to lift really heavy weights? It's quite individualized. I want to know a bit more, I guess. Sorry, it's not an answer, but
I think some of it, comes down to your testing out your movement levels. So I had a Hickman line in when I was going through my treatment, and I basically was told I couldn't do anything with that. And obviously I did quite a lot, but it was understanding how I felt when moving. And actually, if I felt that, because everybody's is fitted slightly differently depending on their body and how it feels. And I think you can slightly experiment with the movement, but also maybe work with a cancer rehab instructor individually to see what your restrictions are and what you're able to do. And actually, do you need to do those exercises? Are they, like we say, are they your life, or actually can you avoid some of them if they're going to increase that risk of dislodging, or, you know, increase that risk of pulling on that area as well? Yes, I think, Mel, I don't know if you've got anything to add.
Yeah, I think it's similar, you know, obviously where it's sited, they can obviously do exercises on the other side. But I think you know, putting it into perspective, it may just be if you go to sleep on your right side and you always put your arm above your head underneath your pillow, and then they suddenly think, well, I can't do that anymore. And they think, well, okay, well, let's try and do a different movement because you're just used to doing it that way.
Yeah.
But it is, you know, again, it's trial and error, but we've got to stop this. No, you cannot do it. You know, we just work with people to say, well, let's have a go. What do you want to do that's raising your arms above your head? Let's try it with the one side. Okay, how does that feel? No problem. Right, now try this. But again, it's time, isn't it, to do it.
But the other thing is, you're likely to go do your shopping and put your food in the top cupboard. So you've probably already done that with a line in anyway. And I think the main priorities are that it doesn't become dislodged and you don't get it infected, and you reduce the risks of those two from happening. And so if you can do that, then that's that's great.
I agree. I think, again, it's trial and error. Have time. Don't overdo things. But if it's something that you really want to do, well, then we need to work with people to be able to do that.
So if your baked beans are in the top cupboard and your white beans are, you're going to have to get them.
But it's even the same as, you know, washing your hair, putting stuff on the line, you know, you automatically do something. So,
yeah. So I mean, this has been so helpful. I think just adding in, you guys should talk to each other. So not the panel, but people who are listening should talk to each other on our Facebook page, because you will have found ways around obstacles that we haven't heard of, and that, you know, as we said, learning from each other is really powerful. Gemma, have we got any other questions that have come in that you've seen just before we wrap this up?
One of the questions, would something like a stoma bag over a port be waterproof enough? So that was just one of the questions that's come in.
Yeah, I think that would be. I think that's the kind of get around thing that we probably wouldn't have thought about. That's a good idea, actually. But I think ports are, yeah, like Mel said, Tegaderm's probably pretty good as well.
Yeah, and I think oh, sorry, I think you're probably going to go on to this now.
No, go on.
No, if you were just finishing off around, I think Tony's question I saw around why healthcare professionals might still not be talking enough about the benefits of exercise and cancer. And I do think that's still an important one to mention, so that we can continue to push that kind of agenda and make sure this sort of conversation is heard loud and clear. Yeah,
and I would just back that up. Often the answer in the NHS, I mean, I broke my collarbone. For those of you who don't know, as a professional athlete, I broke my collarbone 8 weeks before the World Championships a few years ago. And the NHS advice was, don't lift anything heavier than a cup of tea for 10 weeks. And 8 weeks later, I went and raced an Ironman in Hawaii.
Of course you did.
So that just sums up that the NHS advice is highly over-conservative. And luckily, I found myself a very enabling physio, and that's not cancer. It's, you know, it's a very light-hearted parallel, but it's taught me that where there's a will, there's a way. If you can find someone who wants to help you find that way.
Yeah, and I think I'll just add to that, there are a lot of people that we've engaged with, physiotherapists, oncologists, healthcare professionals within the NHS that we've engaged in, who this is their area, they're passionate about this area, and we're getting lots of referrals. We have, for 5KUA ambassadors, we have a lot of healthcare professionals now involved. So we're going on a movement with cancer and exercise. We're not there yet, like Rebecca and Mel said, the evidence base isn't as strong as we want it, and we're constantly having conversations about how do we make it stronger so we can push this. But also, we're, you know, healthcare professionals are wanting to hear about patient experiences, because they form our dialogue with other patients, they form our experiences, and they form the literature and the anecdotal evidence base that we need to support people living with and beyond cancer.
I think that's so right, Gemma. I can't really add anything to that, apart from, Tony, that I share your frustration entirely, because that's really the main part that I want to focus on in my job. And it is partly that we need to strengthen the evidence. We also need to make some parts of maybe the NHS realise that this is really important, that we can happily get people living with and beyond cancer for longer now, so people are living better lives, hopefully. But physical activity is a really important part of that. And if it turns out, as we think, that it can be very beneficial, hopefully for the cancer itself, but in terms of reducing risk, but also for all the other things that come along with or after a cancer diagnosis. Like we've mentioned lymphedema, but there's lots of other things like effects on the heart and effects on the bones and muscles and everything really. And fatigue, I know, is something for a separate discussion, but yeah, the sooner that becomes something that I hopefully can be seeing people with in the NHS, the better, really, for sure.
And I would just add to that is, you know, if your oncologist or your doctors don't know about it, well, then educate them. You know, often I will see patients who've said, oh, Dr. So-and-so has told me that I'm not allowed to do that. Well, the first thing I would then do is ring Dr. So-and-so and say, actually, you told this to a patient. It's not actually true. The evidence now suggests this. Can I come and have a chat with you about it? Yeah. So it's constantly that 30 seconds elevator pitch, constantly telling people, actually, that's wrong. Exercise is really important. This is why we need to do it. So
I think as well to add, sorry, Mel, to like give maybe a signpost if your GP or even your oncologist, the oncologists know a lot and they often haven't got a lot of time to talk about exercise, but they're often quite on board with it being really important. But there is exercise medicine in the NHS. We do MSK, musculoskeletal medicine, but we also do exercise medicine. And I see a lot of athletes with medical health problems, not just they're not just hurt a muscle or a joint, but that should be something that your doctor or GP can refer to. And if they don't know where it is, then they can look it up, but it does exist. And the more that we use for that, the more that we can become part of what people need. They don't need to see another doctor for ages, but sometimes that's just the doorway in to maybe getting a bit of specific support for what you do need.
Yeah.
So we are here. So.
Yeah,
Right,
I
I am going to wrap us up because I promised we'd be under an hour and I've got 2 minutes. Just to say, we have had a few questions about fatigue. We are planning a workshop, a whole workshop around fatigue. So we thought we'd save those questions. Gemma's looking worried because she's going to be leading it. But we're planning a workshop on fatigue in the next few weeks. And we have now launched a YouTube channel. So we put all our Move Your Way sessions, our Q&As, our interviews, all up on YouTube. So please do check them out. Go back and look at the past ones. We've got some really great content. We're really so grateful to have so many experts like Mel and Rebecca joining us. And please tell other people about us. We hope you enjoy what we're doing. And yeah, the more people that can learn from us, the better. Thank you very much, Mel.
Thanks, everybody.
Thank you.
Thanks, guys. See you later.